still had patients that died of malaria. Just to talk about the importance of this disease in our country. The prevalence itself, we are actually the third country in Central Africa having, the third country in Central Africa with the number of, in terms of number of patients of malaria. Also, this is very important because it affects the patients. The patients generally are very absent from school, from work. We all know that if you're having malaria, you cannot actually work, you cannot go to school and all that. And we can also see that uncomplicated malaria, if not treated, can become severe, which becomes another issue, very much more complicated to treat. Now, this is a little bit of statistic of the year 2020 on the population at risk, the number of deaths, that were signaled to the hospital. Because let's not forget that malaria can kill, but the patient will not be in the hospital, for example, and so we never know what killed him actually. The number of presumed cases and the mortality rate in infants less than 5 years, the number of deaths and the number of deaths due to malaria in children of less than 5 years. Okay, in effect, for malaria, the populations which are at risk of having the malaria are children of less than 5 years. We saw in the statistics how the number of deaths was very high. We also have pregnant women in which the malaria becomes very important to take care, because in that case, the woman and the child are also at risk. We have immunosuppressed individuals. We know that immunosuppressed individuals, they have a difficulty with their immunity. And so fighting against every other pathogen, including the Plasmodium species, will be very difficult, and as such, malaria becomes a problem for them. We have travelers from non-endemic areas. What we have to understand is that us which are living in endemic areas of malaria, we are constantly in contact with the Plasmodium species, meaning that our immunity is constantly in contact with the disease, okay? And so we generally have pre-formed antibodies against the Plasmodium species, meaning that someone that is not living in constant touch with mosquitoes, let's talk of somebody living in France, for example, he does not have that predestined, if I can say, that pre-formed antibody, and so the first contact that he will have with the malaria parasite can be very dangerous for him in case his immune system is not very responsive, which is not the case for those living in endemic areas, and that's the same thing for immigrants from endemic areas. And also, before I forget, the idea also is for immigrants living from endemic areas and moving to non-endemic areas is that in non-endemic areas, malaria is not a burden for them, and as such, they don't have treatments for that. If you realize, you can go in the hospital in Cameroon, okay, and they will always have a treatment for malaria instantly. Talk less of something like a surgeon ready to operate a cancer disease, to operate cancer, for example. That is very common in areas where cancer is endemic. But in our case, malaria is endemic, and as such, every pharmacy has at least one drug that can cure malaria, okay? So if you are an immigrant from an endemic area and you move to somewhere they don't have malaria as a body, there they won't have immediate treatment for that, and such you can die of malaria not because they cannot treat it, but because they are not used to treating it. Now, the species of the Plasmodium, we have the Plasmodium falciparum, Plasmodium malariae, Plasmodium ovale, Plasmodium vivax, and Plasmodium knowlesi. The most important for us is the falciparum, which is mostly present in sub-Saharan Africa. Now, physiopathology. How does a Plasmodium species cause a defect that we term malaria? Actually, the Plasmodium species does not work on its own. Okay, he is mainly present in the blood and in the saliva of the mosquito. So what happens is, you have a mosquito that collects it from an infected individual and moves to and transmits it to a non-infected individual that becomes a secondary host. Now, with that said, there's the Plasmodium species does have a cycle of development in each of its hosts, which we call the primary and secondary host. And so we have an asexual phase of growth in the secondary host, that is the human being, and the sexual phase of growth in the mosquito. Now, the asexual phase, which is the most important for us because that's what concerns the human being, will have a cycle which is outside of the red blood cell and another cycle that is inside the red blood cell. And so, in a human being, in both of those cycles, we have 4 forms of the Plasmodium species. Either it will be a sporozoid, an hypnozoid, a merozoid, or a trophozoid. Okay, before we continue with that part, we would like to say that the incubation period, that is the time taken for the onset of symptoms once you have gotten the Plasmodium species in your blood, it varies for each of the species. For the case of the falciparum plasmodium, that is the case, that is our concern in sub-Saharan Africa, it is of 7 to 12 days. So after 7 to 12 days, once you are bitten by a mosquito, you start seeing the symptoms of malaria. You also have the incubation periods for the other species. Now, as I said, the Plasmodium species will have 4 main forms. Here we have the exoerythrocytic stage, that is outside of the red blood cell, and it finishes by the formations of schisms that infect the red blood cells, and we have a trophozoid that is formed, and the trophozoid end up liberating another amount of schisms. So what happens is, here we have the sporozoid that is from the saliva of the mosquito. It enters the bloodstream of the human being. It moves to the hepatocyte. It moves to the liver, where it infects the hepatocytes, and then it's transformed into an hepatic schism. The hepatic schisms will conserve a great amount of schisms, and at the end of the liver, it will explode inside the bloodstream, liberating a numerous amount of schisms. You see that if you have to calculate the amount of sporozoids that enter here to the amount that is in here, is actually much more greater. Right? So it means that the amount, no matter the bite of the mosquito, it can cause as much symptoms as it could be. So from the hepatic schisms, you have merozoids that will be liberated in the bloodstream that will infect the red blood cells, and the cycle continues until you have a late trophozoid. This trophozoid is important because this is what is tested in the paraclinicals when you are doing what we call the tick smear and the thin smear. All that's what is tested to know the presence of malaria in human beings. So these trophozoids in the trophozoid, the merozoid will also progress, right? They'll also be growing until the trophozoid will also explode, liberating another amount of merozoid that will again infect other cells. Now, this merozoid will also develop. Now, some of the merozoid will also, what we do is, I don't know, it's not metamorphosis because it's in safe way. They will also take another form, that is the gametocyte. And this gametocyte will have, as their gametes, we have a male gamete and a female gamete. And so those gametocytes is what now another mosquito will collect. Those gametocytes now enter the mosquito's bloodstream, enters the mosquito's saliva, where they develop again and grow into sporozoids from where they are injected in another human being. Then the cycle will continue again. Now, the erythrocytic stage. Now, before I continue, I want to tell you that every cell death in the body will cause a phenomenon that we call inflammation. When one cell dies, they start the process of inflammation. And inflammation is characterized by dolor, color, in fact, fever, there's an increase in temperature. There can be edema, there can be redness and pain. Okay, now the erythrocytic stage is the origin of the fever in the human being, because what happens is, as erythrocytes will be destroyed in massive amounts, you saw that merozoids are liberated in massive amounts, okay? So they will infect many red blood cells at the same time, and so those red blood cells will die at the same time, okay? And when they die, there's a huge amount of what we call cytokines in the blood that is liberated. Those cytokines are what we cause, or what we attract the inflammatory cells, causing inflammation in the body. That is generalized, in that case we call it fever. because there will be increase in total temperature of the human being. Now, that's what we say the meteorcyclic cycle is the origin of the cytokines, and there is a fever, and that will cause fever. Now, the fever is a little bit characteristic because the fever will have a late phase, then there will be a spike. That is a moment where the fever is really intense, the temperature rises enormously, and then it drops to not a normal temperature, but a very low amount, a very low degree of the fever. Okay, and so that fever is characteristic for each of the Plasmodium species. For example, here you can see that for the Falciparum species, going towards the third day, you will no more have the fever. You will reduce a little bit, but at the end of the third day, they will have another spike of fever. That will progress to the fourth day. That's a little bit how the fever is characterized. Now, once there is, as I said, once the red blood cell will die, inflammation will be caused. And once the inflammation becomes widespread, we have what we call systemic manifestations. Systemic manifestations indicates that many other organs will touch without the liver counting. What I mean is, the widespread inflammation will start touching other organs. Okay. In the case of the red blood cells, we see what we call rosetting. Rosetting is you have an infected blood cell, that's a trophozoid, surrounded by non-infected blood cells. Imagine if you have one in the middle and the other red blood cells are not infected. What happens? You have something like a flower, right? That's what is described as rosettes. And so you have rosetting and hemolysis, that is destruction of red blood cells. In the kidney, for example, we have acute renal failure. In the central nervous system, we have cerebral hypoxia and seizures. In the liver, icterus. In the cardiovascular system, you can have a shock, and in other metabolic effects could be acidosis, hypoglycemia, and hyponatremia. So this resumes the physiopathology of the Plasmodium infection. Okay, the Plasmodium infection will first attack the red cells. It's true it attacks first the liver, but for as we said, the fever will start when there will be attack of the red blood cells in the circulation. So the main changes come when the red cells start changing into late trophozoites. When those red blood cells start changing, you all know the function of normal red blood cells. So when those red blood cells have changed, what happens is metabolism is disrupted, because we know that red blood cells, for example, are responsible for the transport of oxygen and other substances. Okay, so when they are affected, that transport will also be affected, and metabolism will also be affected. That can be characterized, as we first said, as hypoglycemia, hyponatremia, because glucose is not much transported very well. Metabolic effects can also be jaundice, that is icterus that manifests itself. Now, changes also could be immunologic, where the T helper cells will be affected. That will affect the immune complexes. Changes also in the red blood cells could be rosetting and hemolysis, as we said. And all that will reach to endothelial activation, platelet activation, thrombocytopenia, that will cause bleeding. That can cause bleeding. Or hemolysis also can cause anemia. You see that bleeding can also complicate itself into anemia, intensive bleeding. Now, clinically, like, okay, I have a patient with malaria. How will it be? The presentations of malaria there are many presentations of malaria. You have uncomplicated malaria, which is the most common. You have severe malaria that arises when malaria is not treated. That's when uncomplicated malaria is not treated. We have malaria in children of less than 5 years, which should be also different, and malaria in pregnancy. Now, of all the signs of malaria, the most important will be fever. As we said, fever will arise when the erythrocytes will start being destroyed, and they will start to kill us. So the fever will be characterized by 3 main phases. You have a cold phase, that is characterized by cold intolerance, nausea, vomiting. You have a hot face, that is the fever increase in intensity. You have a hot and a dry skin. And a effervescent phase where you have hyperhidrosis, drop in temperature, and the person seems being well, whereas he's actually dying. Now, fever could also be associated with other signs, which could be asthenia, anorexia, which could also be headache, myalgia, arthralgia, and abdominal pain. But at the physical examination, this is for the third year and 4 years, physical examination will mainly be probe, will not be mainly signs, but the symptoms are those. Now, uncomplicated malaria, as I said, can progress to severe malaria. Now, what is actually severe malaria? By definition, severe malaria is malaria in a patient. That is malaria that we have characterized either by doing a blood smear and a thick smear, and realizing that there is a parasitemia. That is, you have found trophozoite in his blood cells, or we did a rapid diagnosis test, and the rapid diagnosis test was positive. So, severe malaria is malaria associated to clinical and biological signs of gravity, which we will see later, and any evidence of any other organ failure, except for the liver failure, which is also associated with no apparent other cause. That is, you cannot relate it to any other thing except malaria. Now, the clinical signs of gravity, as we said. The clinical signs of gravity, as we said, it will be an abnormal behavior, a Glasgow Coma score of less than 11, a Blantyre score of less than 3 in children. We can have multiple seizures. We can have, let me precise, all of this may not be found in the patient. But, okay, we can have any of these. So we have more than 2 seizures within 24 hours in the patient. We can have generalized states of weakness, a prolonged vomiting, that is more than 2 episodes of vomiting within 24 hours. An icterus, high temperature, characterized by rectal temperature of more than 40 degrees and axillary temperature of more than 39.5 degrees, or a cardiogenic shock. It will also be significant bleeding, that is epistaxis. We also saw in the pathophysiology that earlier. We also saw in the pathophysiology that the plasmodium infection could cause bleeding. So you can have significant bleeding, that is epistaxis, gum bleeding, and hematemesis. You can also have a pulmonary edema, characterized by saturation less than 92% at the room air, or respiratory rate at more than 30 minutes, which is more than 30 cycles per minute. Let me precise. Okay, my classmate will continue.
Thank you. Well, to continue from the clinical vignettes that we proposed, so after talking about the clinical signs of malaria, of severe malaria, so we are going to talk now about the biological signs of malaria, which include the first one was severe anemia. Severe anemia is defined as hemoglobin less than 5 grams per deciliter, or hematocrit less than 50% children as shown here, less than 12 years, or the value shown above. Severe anemia is generally due to the excess amount of hemolysis caused by the parasite. We have acute renal failure, characterized by the different clinical values we have here. And the acute renal failure is a result of either we have stimulation of immune complex that's going to cause maybe a glomerulonephritis, or the presence of rosetting of red blood cells that will clump or disrupt the blood flow at the level of the kidney, which can cause acute renal failure. The third one is acidosis. Acidosis, we could have a base deficit as shown here, or serum bicarbonate as shown here. The acidosis is generally due to alteration of the metabolism. We saw that metabolism could be affected. There could be a switch from metabolic aerobic metabolism to anaerobic metabolism, because red blood cell rosetting can clump and cause ischemia to some organs. They are going to switch their metabolism to anaerobic, which can cause acidosis, and the lactic acidosis as shown. We have hypoglycemia with the value shown here, and hyperparasitemia. For the hyperparasitemia, according to the WHO, it should be greater than 10% in non-endemic zones, but in endemic zones of malaria, the parasitemia should be greater than 5% in endemic zones. Next. Now, moving on into diagnosis. As we said, the clinical signs of malaria are not specific. They are not specific. So, this is an adage. Any fever with a poor clinical exam in an endemic zone of malaria should be considered as malaria unless proven otherwise. And with the exception being baby less than 2 months, because baby less than 2 months, the prevalence or the species or the organism responsible for infection are mostly bacterial infections. So, as I said, other causes of fever should be excluded. The clinical diagnosis is of low specificity because you can have possible overtreatment of patients with malaria and is confirmed by biological exam showing the presence of parasites. Next. So the diagnosis is mainly biological. Biological, we have rapid diagnostic test or RDT. The RDT helps us to detect an important antigen found in Plasmodium falciparum species, especially the histidine-related protein 2. And we could also have the pan-specific lactic dehydrogenase and albumase found in all species, but generally the RDT is mostly to detect either the antigens shown above. Now we have also 2 types of smears. We have the thick smears and the thin smears. The thick smears enables us to detect the parasitemia between 10 to 15 microliters, while the thin smears, although it helps us to detect parasitemia, its main role is to detect the species of Plasmodium responsible for malaria. We could also use the PCR method, but it has generally not been accepted in our cases because it's not very specific or sensitive. And we could also have other exams for the diagnosis of malaria, which could include complete blood count. Notice that the other exams here are for the etiology and also for possible differentials of malaria. That's why we could have blood culture, blood urea nitrogen creatinine, arterial blood gas analysis, chest x-ray, lumbar puncture, or plasma glucose levels. Now, possible differential diagnosis of malaria include with the different amount of signs we could have in malaria. Any signs could be correlated to another disease that's not malaria. So in front of fever, you may think of malaria, but it could also be either a typhoid fever or a urinary tract infection, for example. In front of a coma, for example, it could be either the cause could be either meningitis or meningoencephalitis. In front of seizures, the seizures could be as a result of the fever. Fever can cause seizures that are known as febrile seizures. It could be meningitis or meningoencephalitis. In the presence of respiratory disease, as we said, acute pulmonary edema, it could be as a result of pneumonia. And in the presence of hematuria, it could be due to some disease-specific disease that we encounter in Africa, that is glucose 6-phosphate dehydrogenase deficiency or sickle cell anemia. Now we are going to move on to the treatments. Now the goals. The goals treating malaria, the goals are 1, to ensure rapid recovery in the patient. We have seen that it can cause school and work absenteeism, and that's not efficient for the patient. The second one is to reduce the mortality and morbidity of the disease, prevent progression of uncomplicated malaria to severe malaria, to reduce the impact of infection on the fetus during pregnancy, prevent emergence of resistant species, and the methods proposed could be either non-pharmacological and non-pharmacological. So concerning the pharmacological method, the one that is currently adopted in Cameroon is the use of ACT, artemisinin combination therapy. And the curative drugs include the one listed above, and the most important we have here are the first line and second line. Artemether plus lumefantrine as first line, and artesunate and amodiaquine as second line. The rest could be used, but this one are the most commonly used, and they are the one that should be given when a patient comes and you have a positive diagnosis of malaria. So this is just a table that shows the dose that will be given. We have the dose of artemether and lumefantrine here. Next slide, please. Here's the dosage of artesunate and amodiaquine in infant, the weight given here at the table here. Next. Okay, that was for the curative drug. Now you have adjuvant therapy. Adjuvant therapy is simply a therapy installed in the presence of other signs and symptoms that are non-specific to a particular disease. So, in the presence of fever, for example, we could use tepid sponging, fanning, or acetaminophen at the dosage that is shown here between every 4 hours if the temperature is greater than 38.5 degrees Celsius. Notice that non-steroidal anti-inflammatory drugs should be avoided, especially in children, because there is an increase in the susceptibility to have a Ray's syndrome. And Ray's syndrome is one that is usually present when a child infected with another infection that's not bacterial, or maybe it could be bacterial, but takes non-steroidal anti-inflammatory drugs. because the hepatocytes are not yet mature, they could cause several hepatic encephalopathy, for example, in the Rett syndrome. And they are also avoided because they have a higher susceptibility to produce gastrointestinal bleeding. In the case of vomiting, the presence of vomiting, antiemetics could be used, and they should be used in caution. Why in caution? Because generally, antiemetics, when used especially in children, they can cause sedation. So that's why they said they should be used with caution, because they are potentially sedative. And this is the dosage that was proposed here. And concerning the seizures, when a patient has a seizure episode, for example, an epileptic crisis, you should maintain the airways patent, and you could use parenteral or rectal anti-epileptic drugs like benzodiazepine. Now, that was the therapy proposed for uncomplicated malaria, whereas a patient can take the therapy in an outpatient ward. But if the patient has signs of severe malaria, here's the proposed pharmacological therapy. For severe malaria, first line should be intravenous or intramuscular artesunate at the dosage proposed here. The second one should be quinine. And notice that quinine is given or associated with dextrose because quinine has a higher propensity to cause hypoglycemia. That's the reason why we're associated with dextrose to prevent the onset of hypoglycemia in a patient. Or in third line, you could use intramuscular artemether. And notice that this is very important. Every pregnant woman that comes with a positive malaria diagnosis should be treated as severe malaria. Next. So this is a table generally that will globalize the manifestation that will have complication of malaria and the different immediate management that are proposed with the different signs of severe malaria. Next. And here's an algorithm that we have concerning malaria, the onset of malaria in Cameroon. This is a sign that usually goes in Cameroon. So we could have a history of fever. Now, if the patient comes with fever and has signs of danger may be due to hemodynamic instability, for example. If yes, he should be taken either to a next center health or taken to the hospital where they will have to do a rapid diagnosis test or microscopy where we're going to test for the presence of parasite. If positive, start the treatment. If negative, will be fair. And the guidelines is well illustrated here. Yes. Concerning when you treat the patient, it's very important that you also follow the patient or the disease. So when treated, hemodynamic needs to be monitored. For example, blood pressure, because severe malaria could show as cardiogenic shock. So blood pressure should be measured, temperature should be measured, the oxygen saturation, respiratory rate, and the coma score should also be measured and monitored. And concerning the biology, you should have also your complete blood count, your serum electrolyte, and your blood urea nitrogen and creatinine always ready to monitor. Now, concerning the preventive measure, this will be the last preventive measures, both pharmacological and non-pharmacological, and it's especially suitable for the population at risk. In pregnancy, the proposed drug for first-line preventive measure is sulfadoxine pyrimethamine, and it should be started in the second trimester after week 13 because sulfadoxine and pyrimethamine are drugs that are potentially toxic to the fetus. They are teratogenic, so they can cause congenital malformation. Usually they should be started at the level of the second trimester and should be associated with low folate dose because they have high propensity to cause folate deficiency. In children less than 5 years, it will still be the sulfadoxine pyrimethamine at predefined interval and at the monthly dosage. And the non-pharmacological method will be the usage of long-lasting insecticide-treated bed nets and the destroying possible reservoirs of larval growth. Now, the next set of individuals we are going to talk about are travelers from non-endemic regions. Travelers from non-endemic regions, when they are to travel into a country where malaria is said to be endemic, this is the proposed therapy that's proposed to them. You use atobacone or proguanil, and the dosage 1 to 2 days before they travel, daily during their travel, and 7 days after leaving, or it should be given chloroquine, mefloquine, or doxycycline. The dosage shown above. So to conclude, we could say that malaria is a parasitic disease characterized primarily by the infection of erythrocyte and hepatocyte. The cytokine storm that occurs during red blood cell bursting is responsible for the systemic manifestation. The main clinical panels are uncomplicated and severe malaria. Every fever in a non-endemic zone of malaria should evoke malaria as one of the possible diagnoses. Malaria in Africa, especially sub-Saharan Africa, is treated using artemisinin combination therapy as first line, and prophylaxis should include population at risk to contract severe malaria. This the reference we use WHO malaria guidelines, Marshall C. Runge and Andrew Grenati Leaders Internal Medicine, the CDC, and the Guide de prise en charge en palliative au Cap. Thank you for your kind attention.